Hello, everyone, and welcome to today's webinar, EBV Testing, a Laboratory Perspective, an overview and update on current testing techniques. I'm Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Bio-Rad Laboratories. To learn more, visit biorad.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speaker for today's webinar, Dr. Kevin Foley, Director of Clinical Pathology at Kaiser Permanente Northwest Laboratories. Dr. Foley, you may now begin your presentation.
Hello, everyone. Welcome to this talk on Epstein-Barr virus. My name is Kevin Foley. I'm the Director of Clinical Pathology for Kaiser Permanente Northwest. Kaiser is a large health management organization, big health system, and our Northwest region covers about 635,000 patients in Oregon and Washington. And I'm here at our regional laboratory in Portland, Oregon. And this is where we perform our EBV testing for our patients. And so we're going to talk about the laboratory testing that we can do for EBV and, of course, the clinical implications of EBV. So for this talk, we're going to talk about the virus itself, look at the virion, how it's structured, the infection that EBV causes. And very interesting aspect of EBV is we're learning more and more about its oncogenic properties, its role in cancer. We'll talk about that. Of course, the various tests we have to detect EBV, and then how to interpret that and put that into a clinical context. And then finally, I'll briefly talk about some of the workflows and algorithms that clinicians use around EBV and what we do here within our own health system. So the EBV virus was first isolated by Dr. Anthony Epstein, who was actually knighted. He's a British pathologist, and he was knighted for his discovery. So he's Sir Michael Anthony Epstein. And he just actually died in 2024 at the ripe age of 102. And Epstein and his colleagues isolated the Epstein-Barr virus in 1964 from a lymphoma patient in Africa. And as we'll see, EBV is associated with lymphomas. And so this patient, this correlation, this finding in a lymphoma patient is what we would expect with EBV. It's a double-stranded linear DNA virus, and it's in the herpes family. And you can see here it's got a viral capsid, which will become relevant later when we talk about antibodies to this capsid protein here. And the big thing that many of you have probably already know is that most of us have been infected with EBV. It's very ubiquitous globally throughout all humanity. About 90% of the world's population has been exposed to and infected by EBV. Most of us have been asymptomatic with that exposure, and we'll talk about that. But the primary phase is you get a primary infection and then a latency where the virus will stick around. And in some folks, usually those who are immunocompromised, immunosuppressed for some reason, you can also get a reactivation phase in some of those patients. And as I mentioned, EBV is now known to be an oncogenic virus. And even thought to be a contributor to some autoimmune disease. So whenever I'm talking about EBV, I always kind of talk about CMV as well, briefly, just to distinguish the two, because I found, especially with students, that people tend to conflate the two viruses because they're very similar in a lot of ways. They're both in the herpes virus family. They have the same transmission and route of infection, which is primarily through saliva, and they're ubiquitous. So CMV is also present in most of us, or at least a lot of us, half of us. A third of all children are infected with CMV by age 5, and about half of adults have been infected by age 40. And so it's one of those global viruses, and it can reactivate later in life, just like EBV. But EBV on the whole is worse. It's much more likely to cause an infectious mononucleosis, a more clinical detection, a more clinically significant infection. Splenomegaly, sore throat, swollen lymph nodes, more likely with EBV. And EBV is also the stronger oncogenic risk factor too, compared to CMV. So why do we talk about CMV, or why is CMV important? Because as you probably know, it's a concern for immunocompromised people as well, especially neonates. And so some babies who are born with CMV can have brain, liver, spleen, growth problems. And so, like, as many of you in the lab setting will know, we test blood units, blood products for hepatitis and CMV, which kind of brings up the question, why don't we test blood products for EBV? Since, if CMV is in at least half of adults, EBV is even higher than that. It's 90% of adults. So why aren't we testing these blood products for EBV? That's a good question. But the thought is that since most EBV infections are mild or asymptomatic, screening would actually just lead to a lot of positive units and thus fewer donors, which is not what you want when you have a limited blood supply. So we don't want to exclude donors unnecessarily. And because it's not usually a significant infection, it probably wouldn't have a big change on patient safety. And that's contrasted with CMV because, as I said, CMV has that role in transfusion-associated infections with neonates. And so it does have a bigger impact kind of in that inpatient neonate setting, whereas EBV does not have that same risk for the neonate. So that's why we screen for CMV, but not EBV in blood products. So with that aside, to contrast CMV with EBV, let's talk about the viral cycle of the Epstein-Barr virus. So it's usually contracted through the saliva, through the nasopharyngeal mucosa. So if a virus gets in to the nose, or actually most often through the tonsils, which are lymph nodes in the throat, gets through that epithelial layer, infects those epithelial cells, and then of course you'll have an immune response. Your body will elicit an immune reaction. So you'll have B cells coming to attack that virus, and of course T cells, which can help augment that, which are necessary to further stimulate that cellular immunity. And after the B cell does its thing and acts like a B cell, it will go into a memory cell phase. Okay, so after that naive circulating B cell encounters EBV, it will become a memory cell, and that memory B cell will deposit in a germinal center within a lymph node. Okay, they also circulate in a quiescent state, but most of them are going to be in those lymph nodes. And the role for that cell is it memorized that antigen. It memorized that EBV antigen. And so the same EBV protein that activated its parent B cell, it now is primed to recognize, right? It's a memory cell. So years later, that memory B cell can be triggered in an immune reaction when it encounters that same antigen again. And so again, yeah, they have the same receptors as their parent B cell did. And so they'll bind that EBV, or they'll attack that virus. And so you can see in this nice little diagram here in this gray boxes, they show several proteins, and these are proteins that are expressed by the virus itself, not by the B cells. And some of these we'll talk about. These are proteins produced during the different stage of viral replication, and we can sometimes detect them or detect antibodies to them. So you can see also from this chart that one of the ways B cells are activated is via T cells. So it follows that if a person has a deficiency of T cells or of B cells, then EBV is more likely to go from a latent infection, where it's just hanging out in those germinal lymph nodes, and then it can go from latency back to infectious. And so that's your reactivation, which can occur if someone is immunocompromised. So that's the basic viral cycle for EBV. So it's about 120,000 EBV infections documented, confirmed EBV infections each year in the USA. So it's not a huge load, but then again, most infections are going to go undetected, right? Because they're asymptomatic. It often occurs in childhood. We probably all know this from our high school days. Usually mild and asymptomatic, but also can present as infectious mononucleosis. And as I said, the typical transmission route is through bodily fluids, the so-called kissing disease. 30 to 50% of infected adolescents will actually develop a visible infectious mononucleosis that we can see in a peripheral blood smear, where we can see reactive lymphs. But the big thing is that the virus is usually persistent throughout the adult's life, throughout the individual in a dormant state, as I said. Usually doesn't reactivate, but it can reactivate. But if you have a healthy T cell response and a good immune system, then you'll keep that in check. You'll keep that virus in check, and you'll never get that reactivation phase. But if your immune system is disrupted, then you do have that risk of reactivation. And that reactivation and the severity of the initial infection is the risk factor for malignant transformation. And we'll talk about that in a second. So infectious mononucleosis is seen in usually about 1 month after transmission. So one month after contact, you start to kind of see symptoms. And this is what we all see in the lab, right? We see reactive lymphs, kind of this ballerina skirt appearance where you get scalped margins and indentations along the RBCs. You also see vacuoles in the cytoplasm. And it's important to remember that not all reactive lymphs are caused by EBV. They're not all caused by mono. There are other viruses that can cause reactive lymphs, right? Like CMV, Toxoplasma, Treponema, Pallidum, so syphilis, Group B strep, that's a big one, hepatitis C, hantavirus, there are others. So lots of viruses can induce infectious lymphs or reactive lymphs like this. So what is the typical mono? If you do have symptomatic mono, what does that look like? Well, you're probably familiar, sore throat. So you get that pharyngitis, you get fatigue, that's the big one, and it's definitely the longest lasting symptom. The fatigue can linger for months, even after recovery. You get swollen lymph nodes. Rash is seen in only about 5 to 10% of patients will actually present with a generalized viral rash shown here. You can get splenomegaly, hepatomegaly. Teenagers and adults tend to show symptoms about 2 to 4 weeks after infection. And as I said now before, children are usually asymptomatic, but if they do show symptoms, it's usually a mild flu-like presentation. Interestingly, there's no treatment for EBV infection. Unlike other herpes viruses, acyclovir has no demonstrable benefit in an uncomplicated infectious mono case. So they don't give folks acyclovir. Sometimes they might give a corticosteroid if there's risk for airway obstruction because the tonsillar enlargement is so big or there's so much inflammation going on in the throat, but that's rare. In a renal transplant patient, they might use interferon alpha to sort of kickstart the immune system in those in patients with active EBV. But again, that's kind of a rare setting. So mostly there's no treatment. It's just enduring symptoms and usually will resolve within 2 to 4 weeks. But the differential diagnosis is kind of interesting and important. So if someone presents, there's lots of things that can present with a sore throat, right? So this starts us thinking about why and how we test for mono, and do we need to test? The big one to rule out is just other viral pharyngitis, right? There are lots of viruses that cause sore throats, coronaviruses, influenzas, lots of things. Most of our sore throats are never identified. The viral agent is never identified. Of course, you can have strep throat too, so you might want to rule that out. Toxoplasmosis, more rare. Also, acute HIV, something you want to consider too. So those are really the 4 main other things that it could be, and this is where testing might help you, or maybe it doesn't. We'll talk about the need for testing and how useful testing is in the clinical context. So the oncogenic role of EBV is something that a lot of folks aren't familiar with. And the way this kind of was stumbled on is that it was noticed that in Asian countries, EBV infections tended to occur earlier in life, in childhood. Whereas in Western countries, EBV infection was more in your teenage years. That's what we're used to. And so, that pattern was well known. And then if you kind of superimpose on that, another finding, an observation that in Western countries, Hodgkin's disease, okay, so Hodgkin's lymphomas, which is just a B cell cancer of the lymphatic system, where you see those characteristic Reed-Sternberg cells. Hodgkin's disease was in the Western countries, in the US, it tends to be in early adulthood, where again, it's earlier in Asian countries where it peaks in childhood. So taking these two patterns, people just started to kind of hypothesize that, well, maybe one leads to the other because we see this same kind of temporal pattern. And that turned out to be true. Epidemiologic studies revealed that's true, that EBV is a risk factor for Hodgkin's lymphomas. And since then, EBV has now been implicated in other cancers as well. And this isn't really that new of a concept. We know that there are other oncogenic viruses out there. It's thought that about 15 to 20% of all cancers are caused by virus or induced virus diseases. So there are at least, I don't know, 7 or 8 different oncogenic viruses like Kaposi sarcoma, associated herpesvirus, hepatitis B and C have oncogenic properties. HPV, most people are familiar with HPV's role in cervical cancer. Merkel cell, papillomavirus, human T, lymphotrophic virus, even H. pylori is associated with gastric cancers, for example. So there are lots of oncogenic viruses, and clearly not all people who have EBV infections develop cancer, right? We don't see 90% of people with EBV developing cancer because 90% of us have been exposed to EBV. It's just that the risk of some cancers is increased in those who had a symptomatic EBV infection, usually early on in their childhood. So this oncogenic property gives it a bigger health impact than most folks probably are aware of. In fact, there's this International Agency for Research, which is an intergovernmental agency that's part of the World Health Organization. In 1997, they actually classified EBV as a group 1 carcinogen. And it also has this public health impact probably on multiple sclerosis. There are now at least a dozen papers talking about multiple sclerosis risk with EBV. So it's thought that there's probably as much as a 30-fold increase in risk for MS in patients who had symptomatic EBV infections in adolescence or early adulthood. Now that risk is still small, but it's higher, maybe 30-fold higher with that EBV history. But the 6 big cancers that have been linked to EBV are Burkitt lymphoma, diffuse large cell B lymphoma, Hodgkin's lymphoma, which I mentioned, nasopharyngeal carcinoma, NK T-cell lymphoma, and gastric carcinomas. And a 2020 public health study showed that these 6 cancers counted for about 250,000 new cancer cases annually. So EBV has a bigger public health impact than a lot of people probably realize. So let's talk about the testing. So as I kind of alluded to earlier, a clinical diagnosis is usually all that's needed. And a lot of clinicians just do this. They just look at the presentation of the patient, the history, the age, and they say, yeah, it's probably infectious mononucleosis caused by EBV. Let me know if you don't get better in a month. And so a clinical diagnosis is very common without any lab testing. But lab testing is still used quite a bit. And we have some options for lab testing that we didn't in the past. So we have better panels now than we used to. Certainly, even when I started in the lab, we were basically just doing monospot tests, but we have some more options now. So in our own lab, we do quite a bit of testing. I'll show you some stats at the end, actually. But the tests that we kind of have in our toolbox are the Monospot, and then we have various antibody markers for viral capsid antigen, an antibody for the early antigen, an antibody for the nuclear antigen, and then there's even a PCR test available now as well. So we first have to talk about the classic Monospot, which is actually a really interesting little kind of history story. Dr. Bunnell, way back in the 30s, noticed that there were heterophile antibodies present in humans that react with sheep red blood cells. Okay, so Dr. Bunnell just showed that in time of virus, when someone has a viral infection, they can have this agglutination effect on these sheep antibodies, or on these sheep red blood cells. And a heterophile antibody just means that a human antibody that will react across species lines. It will bind to a non-human protein of some kind. And so back in 1932, he published that this happens in viral infections. You get this non-specific viral associated agglutination. Okay. And then later, about 30 years later, they found that horse red blood cells are even better than sheep. And then they also found that there's this pre-treatment you can do with a specimen to absorb some of the less specific antibodies with ox red blood cells and guinea pig kidney. And so this kind of new modification became known as the Monospot. So that is when we started calling this test the Monospot back in 1964, when these new revisions to the procedure came. So if you've been in the lab and you've done this test, not all labs do this anymore. Our lab no longer does the Monospot, but you would add a drop of patient serum, mix it with a drop of that guinea pig kidney stroma, and that helps increase the sensitivity. And then you add 10 microliters of horse RBC suspension, and you look for agglutination. And if it's there, then you call it positive. And again, this is a very non-specific test, right? It's just detecting viral associated antibodies, which is not the same thing, obviously, as detecting a specific antibody for an EBV protein. Okay. And this agglutination that you observe in the Monospot test can occur with any antibody, IgG, IgM, IgA, but the main antibody in the Monospot reaction is the IgM antibody. So the Monospots, it's kind of, going away. Some would consider it an obsolete test, but you'll see it's still in some algorithms that are published today. People still use it. This overall sensitivity for EBV infection is about 75%, not great. Specificity is better. It's important always to add the caveat that you don't want to use it in children under 4. Okay, it's going to have low sensitivity. You're going to get a lot of false negatives there. And it's just lower in general in early infection, okay, in that real early acute phase. And the CDC actually no longer even recommends Monospot testing, which is interesting. But the low sensitivity means that it's not always going to detect a true positive. Okay, the sensitivity is weak because during the first 2 weeks of infection, antibodies are low, so you're going to miss those. Okay, but the specificity is good. Okay, so what does that mean? That means a negative is likely to be a true negative. So while a positive result doesn't, rule in EBV, a negative result, if obtained during actual onset of symptoms, during actual active infection, a negative result can be useful in ruling out EBV. Okay, so I'll show you an algorithm that uses that power, that performance at the end. I found this interesting little paper from 1982 that kind of gets at when is Monospot testing useful, or at least it helps me understand kind of the presentation you're going to see when you get a positive Monospot. So this group looked at the predictors of a positive Monospot or a positive heterophile antibody test result. And you can see the likelihood ratio of a positive result here. So if you had axillary lymphadenopathy, so, swollen lymph nodes in the armpits, 21% chance that your Monospot would be positive. And likewise, you can see for cervical, so for neck lymph nodes, or palatal petechiae, so this is red pinpoint spots on the roof of the mouth, or inguinal lymphadenopathy, so that's groin lymph nodes. You can see that, when those are present, your likelihood of a positive result is increased. But the point of this paper is that they show that out of 70 different virus-associated symptoms that they looked at, only these 4 here on this chart, only these 4 were found more often in Monospot positive patients. So they basically concluded that if the patient didn't have one of these 4 symptoms here, one of these 4 signs, then don't even do a Monospot, because your odds of it being positive are so low that it's not worth doing the test. So I thought that was interesting, because the takeaway seems to be that the Monospot testing is really only useful when the patient's pre-test probability is already pretty high. So how valuable is this test really? You probably could have diagnosed it just from the swollen lymph nodes and the other symptoms that the patient has. So these are the reasons that the CDC no longer recommends it, and the sensitivity being low early on is the other reason. So as I said, our lab no longer does Monospot. It's not thought to add a lot of clinical value, but as I said, it still is used by some clinicians as a rule out. So much better than that, we have specific antigens that we can get antibody responses to with EBV. Okay, so the first one is the viral capsid antigen. So again, this is with all of these tests. Actually, I'm going to show you this diagram on multiple slides. These are all antibodies, so it's important to remember that this isn't like hepatitis where we sometimes measure antigens and antibodies. Everything we're looking at here is an antibody. So these are all patient-elicited antibodies to various EBV antigens. Okay. It's also important to note that these serologic marker time graphs are not standardized. If you search for a graph like this, where serologic markers over time for EBV, you're going to see x-axes that are very different. Oh, maybe not very different, but significantly different. You'll find lots of different images with different x-axes, and that's just the way it is. None of these follow very strict guidelines, right? So I've actually made this x-axis nonlinear to drive home that point that these timelines are variable. So just be aware that no two graphs plotting this will look exactly the same, but these are general trends that you see. So the first thing we usually see is the VCA antibody, IgM, appearing. Okay, so like all serologic markers, the IgM precedes the IgG, so it shoots up quickly in the first week or two of infection, and then again, like IgM does, it will tail off after that initial phase. Whereas in contrast, the IgG will stay elevated usually for the life of the patient, for the rest of their lives. So it'll peak at 2 to 4 weeks, persist, and then be detectable or measurable from then on. The other marker that we can now measure is called the early antigen, or EA. And so antibodies against this EA protein are actually polyclonal. So EA represents several proteins that are produced by the virus, proteins that are important in its DNA replication. So when you say EA antibodies, it's a whole complex. In fact, there's two categories, EAD and EAR. So the EAD stands for diffuse. These are just proteins that are encoded by a gene called BMRF1. And then the EAR, the restricted EA proteins, are encoded by a BHRF1 gene, and P85 is the main protein there. But there's a lot of proprietary information. People don't always tell you exactly what antibodies they have against these proteins or what proteins are eliciting their antibodies. But you can look that up for future reading or further reading if you're interested in the difference between the diffuse and restricted. But we call the whole pot EA antibodies. Okay, and these EA antibodies will appear in the acute phase of illness. So when you're symptomatic, after week 2, and then it will fade and usually becomes undetectable after 12 to 24 weeks. So for most patients, it's a good sign that they're in active infection. If you can measure EA antibodies, it's probably active infection. However, about 20% of healthy people will have that EA persist for years later. So not everyone, but most people, it's a good predictor of active infection. And then we also have the nuclear antigen antibody. So antibodies against that nuclear antigen. And these are not seen in the acute phase. This is the slowest and last antibody to rise. So titers will increase here after a couple weeks, about a month later, and then it peaks at around 4 months. And again, like the VCA IgG, it will persist for the life of the patient. So if you've had EBV, which most of us have, you'll have detectable EBNA as well as VCA. So when you take these markers together, you can do some rough estimating of where the patient is with regard to their infectious cycle. So you can see in table form the graph that I just showed you. I prefer the graph, but a lot of people like the table. And you can see, like, for example, in the acute phase of infection, you would expect to see the VCA IgM. You may or may not see the IgG, depends on, when you're catching the patient. And you're going to see that active EA antibody as well. And then The nuclear antigen is going to come along later. So that's kind of telling you that the patient's probably in their recovery phase, that the acute phase is done, and hopefully they're recovering at this point. And then you always have to be mindful that some patients might have that reactivation, those immunocompromised patients. And if that happens, you can actually see the IgM come back for the VCA. So you can see a subsequent reactivation of that IgM response. And same is true for the EA. You can see that flare up again. So those are the two that become useful for measuring reactivation in patients. So in our lab, it's very nice. We have a panel now using the multiplex testing offered by Bio-Rad. We use our Bioplex instruments. We have 2 Bioplex that run all day. And one of the tests we do on those is EBV. And the EBV panel, and this is use multiplex bead technology, and it will measure VCA, both IgM and IgG, as well as the nuclear antigen and EA. And it even has a heterophile IgM, which is interesting. So it's not the Monospot, it's not that test, but it is measuring a nonspecific heterophile IgM. So it's kind of a surrogate Monospot test. These Bioplex assays are not qualitative. I'm sorry, they are qualitative, they're not quantitative. So we don't report numbers with these. We just say positive, negative for each of these markers. And the nice thing is a lot of people are using this methodology now. I looked, we use the College of American Pathology, CAP, as our proficiency testing resource. And I just checked this morning, and we have 130 labs that are peer labs of ours that use this method. So we have really good comparators, and we can compare, our proficiency testing to that. So it's a pretty good peer group, and we've had really good consensus with our proficiency testing samples across labs. You may not have noticed, but in all the graphs that I was showing you, we can also see this line here, which shows that we can detect EBV DNA in serum. So we now have PCR tests for Epstein-Barr virus as well. It's definitely not common. When would you use a PCR test for EBV? Usually it's going to be in a pretty complex case. Usually in the context that I've seen it, the rare context, it's to help uncover an EBV-associated central nervous system disease. So a patient that's immunocompromised, who is presenting with some kind of neurologic manifestation. Could be a CNS lymphoma, encephalitis, meningitis, neuritis, facial nerve palsies, hemiplegia, so like paralysis on one side of the body, some kind of CNS presentation, and an immunocompromised patient, usually due to HIV/AIDS. And so these patients can be pretty complex, and CSF testing for EBV DNA actually becomes useful in such patients to see if that's the causative agent. And this is what a typical result would look like from a reference lab. You can measure this in CSF, as I just mentioned, amniotic fluid, bone marrow, other body fluids. So it's detecting viremia, right? It's detecting active viral copies or viral shedding. You could see it in asymptomatic individuals if they have, a low-level viremia, but it's really intended for those patients with a complex history where you're really just trying to see if EBV is the cause of their complex presentation. A couple of publications have proposed that a threshold of about 10,000 IUs per mil, or about 2,000 copies per mil, is kind of a good diagnostic cutoff for chronic active EBV disease. So you can see in this kind of test sample patient report here, there was 223 IUs per mil. So that'd be like a very low level, probably not indicative of that chronic active infection. So PCR assays are available out there from reference labs. And interestingly, the last test I thought I'd mention, because it's kind of new, is genetic testing for EBV. So why would you ever do this? Well, you're not testing for EBV, you're testing for susceptibility to EBV, okay? So there are labs, as you can see here, here's a sample report of a lab that's testing 25 genes here. And these are all genes that are related to T cell activation or immune cell function, T cell receptor signaling, receptors for cytokines like tumor necrosis factor alpha, things like that. So they're looking for genetic variants that will unmask or reveal that the patient has impaired immune system, okay, which would make them more susceptible to EBV. So it's an EBV susceptibility panel, okay? So pretty interesting. Obviously going to be a very esoteric use, very, very limited and rare use, but might help with the workup of some complex patients. And as I said before, most patients are going to be able to keep our latent EBV in check. We're never going to have that reactivation. But folks with genetic mutations, polymorphisms in these genes, they're going to be more likely to have that reactivation. Okay, so they might have that that risk, and that may be useful for some specialists to be aware of. But let's kind of bring it back to the common primary care application, which is obviously what most of us are going to see in our laboratories. So I looked at some current recommendations from the American Academy of Pediatrics and the American Academy of Family Physicians, and basically this is what they say about EBV testing. And you can see how kind of generalized a lot of these guidelines are. So they say that nonspecific heterophile antibody testing can be useful. So the Monospot, for example, can be useful during the first weeks of illness, but not in children less than 4 years of age. An absolute increase in atypical lymphs is useful, but non-specific. Okay. Serological testing can be useful. So like that serological panel I just showed you, that could be useful for evaluating patients who are negative on the Monospot and are younger than 4, or just have a more complicated presentation, or infectious mononucleosis. Their infectious mononucleosis syndrome is not classic, so they're not presenting as normal. Testing for other agents like CMV, toxoplasma, adenovirus, etc., may be indicated. Okay, so again, generalized guideline, very general. They do mention PCR. PCR detection in body fluids or in blood may be useful for immunocompromised patients or complex clinical situations. So it's a lot of maybe useful, might be indicated, could be helpful kind of phrases, revealing that the testing approaches are not that standardized or definitive. Instead, testing can kind of be helpful, but it really just depends on the patient's risk of significant infection or their immunocompetency, et cetera. So not real strict guidelines like we see with a lot of testing. It's pretty loose and generalized. So here's an algorithm that I found, and again, this is fairly recently published in American Family Physician, and this is a typical algorithm for maybe your smaller clinician office, your primary care location, where you're not going to have immediate access to a lot of serologic tests like I showed you. So maybe consider this maybe like a cheaper, faster algorithm where you suspect infectious mononucleosis, get a heterophile antibody test, get a Monospot, and a CBC with a diff. If the heterophile antibody test is negative, and then their lymphs are normal, or their WBCs look normal, you're done. It's probably not going to be Epstein-Barr virus. If the heterophile test is negative, but you still see some atypical lymphs and it's a little bit of a weird CBC diff, then okay, then you can order, maybe send out for a viral capsid antigen IgM test. If it's positive, you're done. Let's call it infectious mononucleosis by EBV. If it's negative, let's call it not EBV. Okay, so pretty simple algorithm. And if your heterophile test or your Monospot test is positive, you can be done right there. And that's enough evidence to just call it EBV. So that's kind of a simple algorithm. The approach that we take and our clinicians take is actually equally simple. It just has more specific testing associated with it. So this is kind of what people are using in our region here. They suspect infectious mononucleosis, and they'll just order that Bioplex panel right off the bat that includes all those markers that are measured simultaneously through the multiplex assay. And if it's positive, they simply note which antibody is positive, and interpret it according to the kinetics shown in that graph. And if it's negative, they rule it out. So a lot more straightforward, not necessarily cheaper, but definitely saves time. And it's a pretty direct way to just go about assessing it. This is what the order looks like. Try to put as many synonyms as we can. Can't see this display, but in the background, we even have Monospot as another synonym to kind of bring people to this test panel so that they all know that they're looking at the same thing. And this is the only test we offer for EBV, is that multiplex multi-marker serologic test. And this is kind of what it looks like. This is exactly how it looks like, actually, in our electronic medical record. You can see the qualitative result there, and we have a text description as well as a interpretation table for the various markers there. So you can see in this patient, the early antigen antibody was detected, as well as the capsid IgM antibody, and that heterophile IgM, that kind of surrogate for the monospot, was also positive. So what does this tell us about this patient? In this patient, it's telling us that they're in the acute phase, right? Because we see the IgM for the capsid, as well as that heterophile, and that early antigen, which is a good antibody to detect active infection too. So this patient's in that acute phase. So lastly, I kind of wanted to sum up by showing some real life data from our lab. I thought this was interesting. I looked at the last year of our testing. We're doing about 100 samples a month, so 100 of those panels a month, and 70% of what we test is positive. Now, at first I thought, oh, that's great. That's a really good yield rate. That means our physicians aren't just ordering this on anybody. Their hit rate's really good. 70% of the time they're getting positive. But that's not the right way to think about it, because many of us are going to be positive for the rest of our lives, right? So you can't really just look at that as acute infection, right? So this is what we see in our lab. About 70% of people that we test will have a positive result of some kind, something positive on the panel. The vast majority, 92%, will have more than one present. But if there is only one present, it's almost always going to be the VCA IgG. So looking at this graph, does this look like overutilization to you? It's hard to say. Since the two most common markers there are the long-term IgG markers, that could mean that just most people that are tested don't have active infection, but instead just have lifelong antibodies to EBV. So we don't really know if it's being overused, this test. It's probably better to look at the acute markers, right? In that case, it's something like 10% of the tested patients in our lab are in the acute phase of EBV infection. And that's actually not bad, as I kind of pondered it. A 10% positivity rate on an infectious disease marker seems pretty reasonable. That's pretty good. That's a pretty good hit rate for a physician. So I still wonder, how many of those patients could have been diagnosed clinically without the test, just from their symptomatology and their history and their presentation. But this to me doesn't look like overutilization. This looks like probably what we would expect to see when we test a lot of people with these panels. So that's it for me. I hope you learned something new about EBV and the important role that the lab plays in this infection, and also that oncogenic risk that's now being more and more associated. And keep your eye on scientific news articles, because they're coming out with more and more associations with autoimmune diseases. I only mentioned MS here, but there are others that are now associated with EBV, as well as the kind of increasing amount of data that we see with other types of cancer associated with EBV. So thank you for your attendance, and goodbye.
Thank you for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask Dr. Foley, please do so now. Just type your question into the Ask a Question box and click Submit. We'll answer as many of your questions as we have time for. Let's get started. Our first question is asking, since VCA, IgG, and eBNA both detect past infection, does one test have an advantage over the other?
Well, yes and no. I mean, well, the early antigen, well, you always have to take these kind of together, like as a conglomerate. But you want to do the IgM, not the EGG. The question was past infection. Yeah, sorry, you said past infection. Yeah, so for past infection, VCA IgG is definitely more seen. Like we see higher titers of that. So I would say that's the more dominant one. That's the predominant one we see. The EBNA is still lingers, and it does present there longer. But in about 20% of people, it's pretty low. So I would say, just based on experience, that the VCA IgG is probably a little bit better for past infection. But you can take both. Not sure there's a strong link for either one being more powerful. I just think VCA IgG is more common.
Wonderful, thank you. All right, our next question says, given the limitations of the Monospot test, is serological EBV testing the most reliable diagnostic workflow currently recommended for early EBV detection in pediatric patients?
Yeah, definitely. As I mentioned, like the CDC doesn't even recommend the Monospot anymore. And one of the reasons is that it doesn't work in children under 4. Children become at risk for EBV infection after they lose their maternal antibodies, right? So testing them early isn't very useful because you might be measuring mom's IgG and not the baby's antibodies. So and then during early childhood, kids don't have those non-specific heterophile antibodies that the Monospot detects for a while. So that's why we don't do it in under 4. So the Monospot isn't even an option for young kids or babies. And it's the EBV specific antibody panel that's recommended for pediatric patients if they need testing. Yes.
Thank you. Oops. Oh my gosh, sorry. All right, our next question says, one can assume there is a correlation between the positivity rate and age of the patient depending on the marker. Do you know the typical age of patients that EBV testing is being requested by physicians in your institution?
Oh, that's a good question. Yeah, that's interesting. When I showed you the volume data there a couple slides ago of what our lab does and how many are positive for each of the antibodies. And when I pulled that data, I also looked at the ages. The average age for testing was something like 30, but that's the average of all those tests. When I looked at the mode, so the age group that appears most often, it was 12 to 19-year-olds. So 12 to 19-year-olds made up about a third of our complete annual volume of testing. So a third of our testing is done in 12 to 19-year-olds. And the other 2/3 was pretty evenly distributed from like ages 20 to 70. But yeah, you see a pretty big spike right there around like 12 to 18 years old.
Okay, wonderful, thank you. Our next question that we have asks, how should clinicians differentiate between EBV reactivation and chronic active EBV disease, or CAEBV, especially in immunocompromised patients?
Yeah, I didn't really talk about chronic active EBV, but that's a very serious condition. It's a systemic inflammation with clonal proliferation of EBV infected T or NK cells. So it's the EBV basically immortalizes those cells and they become clonally proliferating, and it becomes a very serious condition. So the diagnosis of that chronic active EBV, it's PCR. They use confirmation using PCR, and they want to see a pretty high copy number, something like greater than 10,000 IUs per mil has been proposed. And some protocols will also want to detect actual cells, actual T cells or NK cells that are EBV infected. And so there are some labs that offer assays where they actually do fractionated WBC counts, and then they with immunobead harvesting, or I think there's even fluorescent labeled flow cytometry, which is like flow fish methods to actually find the EBV in those specific T cells. So they want both those things, a high PCR as well as finding that in cells themselves. And those are kind of diagnostic criteria for the chronic active EBV. And if you have that, that condition, hematopoietic stem cell transplantation is really the curative treatment for that. They also use chemotherapy as well. But yeah, I didn't really talk about the chronic active EBV, but it's a very serious condition and it requires kind of a more rigorous diagnostic criteria.
Wonderful, thank you. All right, our next question here asks how to diagnose neurological manifestation of EBV, EBV serology in CSF, any role?
Oh, like, so the serology in CSF as opposed to plasma serum. Yeah, you can measure these antibodies I talked about in CSF. It's not very common. In fact, I'm trying to remember if I've ever seen that sent out. We don't do that specimen type here. We don't do CSF here. We just do blood or plasma serum here. There are labs that do take body fluids for those serologies, CSF, but by far more commonly it's going to be PCR. So if you have a CSF specimen and they're worried about an EBV CNS infection, they're going to give you they're going to want PCR testing rather than the serology testing on that CSF.
Wonderful. All right, our next question here. Can you please enlighten about EBV diagnosis in post-solid organ transplant or hematopoietic stem cell transplant?
Yeah, I'm not a transplant specialist by any means. We do have a transplant group here in our system, but I know that they use EBV DNA, so PCR screening before transplant, and then I think I've seen monthly testing as well for the first 3 to 6 months, I think, for those patients post-transplant. I think if EBV is present in those patients, I believe they do a preemptive therapy. I think rituximab is the agent that they use. Rituximab is pretty interesting drug. It kills B cells, and so if you have infected B cells that are infected with EBV, and you can pre-treat with rituximab to try to prevent or decrease the risk for that post-transplant lymphoproliferative disorder, PTLD. That's about all I know, is that they will pre-screen and then they will monitor EBV, and I assume it's for that indication. If they need to give rituximab to decrease their transplant risk.
All right. Next question here. If the CDC does not recommend Monospot, are they recommending the EBV panel alone? VCA, IgG, VCA, IgM, EBNA, and EA, or do you need to add the heterophile IgM?
Yeah, you don't need to add the heterophile IgM. They just recommend serologic markers. That's pretty much it. It's a pretty general recommendation. So no Monospot, but markers, and they don't specifically call out adding the other heterophile marker that we use in our panel. That marker, of the antibodies that are in that panel that I described, the heterophile antibody is kind of interesting, and it's a nice little acute phase confirmatory test, but it's definitely kind of the weakest of the panel. So CDC certainly doesn't require that.
Excellent, thank you. Okay, our next question here. We have a ton of questions coming in, so please keep submitting them. If we don't get to all of the questions, we will answer you. But I know we have limited time here with Dr. Foley. So our next question is, for NPC screening, which EBV lab test is most suitable?
NPC, so is that nasopharyngeal cancer, I assume? I don't know if the questioner mentioned. I'll assume that's what they meant. I don't think there's any screening ever required or recommended for nasopharyngeal cancer. I suppose if there was a really high risk population, they would probably just use a scope, a nasopharyngeal scope, and visually look for that. An EBV serologic marker might make some sense in a patient with high risk, maybe a family history or something like that, or some kind of endemic area. Then I would think any past marker, like an IgG, VCA, might have some utility there, but there's no quote screening test for NPC.
Excellent, thank you. All right, moving along here. Our next question says, you mentioned the role of EBV PCR in immunocompromised patients with suspicion of CNS infection. Is there a role in pre or post-transplant monitoring?
Yeah, I think I probably just answered this a couple questions ago, where for the solid organ transplant question, where they definitely do PCR repetitively to monitor those viral loads over time to see if they're decreasing. Was that the question, or was it CSS specific, or just any post-transplant?
You mentioned role of EBV PCR in immunocompromised patients with suspicion of CNS infection. Is there a role in pre or post-transplant monitoring?
Yes, there is a role. Yeah, like I described, I've seen it every month for the first 3 to 6 months in post-transplant patients who had EBV when they started the transplant.
Okay, excellent. Our next question here, what testing is preferred in cases of malignancy to link these malignancies to EBV as a cause?
Oh, yeah, that's a hard one. You can, as you can imagine, it's really hard to link any cancer definitively, right? It's all about risk, and you can't, you almost can never highly link a causative agent for cancer. You just can't. So we don't really look at EBV testing in that way. We don't use it. An oncologist will not order EBV to kind of get at trigger points that could have caused a lymphoma, for example. Our oncology docs don't do that. They just treat the lymphoma. So epidemiologically, I'm sure there's studies out there that use these markers to somehow correlate risk. In fact, I know they do. I've looked at some of those papers. So you can use them to help correlate risk or correlate or predict risk, but they're not used clinically to back diagnose the causative agent or trigger for cancer. Yeah, unfortunately, it's not that clear cut.
Okay, thank you. We have time for one more question here. So this last question we're going to ask today says, so Monospot is totally out of the question to use?
No, I mean, as I showed, there are algorithms that still use it. I have a friend who's a physician assistant in a rural part of Oregon here, and he uses it all the time because that's what they have on site. And as I said, it can help him rule out mono, and then he thinks, he goes down his other differential diagnosis for the symptoms. So it is still used, but if you have the panel available, then in that context, yes, it's obsolete. So it's like, we have lots of tests like this. I know people who still use CKMB for assessing myocardial infarction, even though that's completely obsolete in my opinion compared to troponin, right? So we always have tests that linger, and Monospot's one of those. I think it's going to linger longer than most because it still has kind of a role in austere environments where you just don't have access to larger panels and you want something fast. So it has some limited utility, like I said, in ruling out. So you'll still see it around, but none of the labs I know in the metropolitan area where I live are using it anymore.
Okay, and we're going to try to squeeze one more question in while we have you. This last one is asking if there could be any risk in pregnancy.
Or EBV.
It
So
doesn't.
I guess,
But
yeah,
I assume it's just asking if there could be any risk in pregnancy. I assume it's with EBV, but it does not mention.
yeah. So like if the mom has EBV, okay. Not really. I mean, a lot of mothers do have EBV. If they're an active infection, I'm sure there's, just some kind of general inflammatory risk. But you don't hear about it as a prenatal screen like you do for syphilis or other things like that, Group B strep. So I don't think it's a significant public health problem, but probably feels pretty bad for the mom if she's in a lethargic mononucleosis state. But I'm not aware of any significant morbidity and mortality with the child during that.
Excellent. I'm going to thank you again for your time today and your important research. We would also like to thank LabRoots and our sponsor, Bio-Rad Laboratories, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.